From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, everyone. Welcome back to the JAMA Oto podcast series. I'm your web editor, Paul Bryson. I'm a laryngologist and director of the Cleveland Clinic Voice Center. And today I'm delighted to be joined by Dr. Matthew Carlson, professor of otolaryngology and neurosurgery at the Mayo Clinic in Rochester, Minnesota. Today we'll be discussing his article on new insights into the natural history of vestibular schwannoma. Dr. Carlson, welcome to the podcast.
Thank you very much for having me.
Yeah, can you tell the listener just a little bit about yourself, what your clinical practice is like, and what led to exploring this topic?
Yeah, absolutely. So I'm a neurotologist or ear surgeon at the Mayo Clinic, and I'm .8, so most of my time is clinical. I have some other hats that I wear as well as most of us do, but most of it's spent in the clinical space. And one of my primary interests around management and decision-making in vestibular schwannoma, also called acoustic neuromas, and cochlear implants. Those are two main focuses of my interests in career and clinical focus. The work, there's different types of research projects you can get involved in, and sometimes a question comes up in the clinical space, and you do the project, and it kind of gives you an answer, and it's kind of done. You're done with that project. And there's other projects you work on where one paper, one project leads to another paper project, and pretty soon you find out that it's going to be a lifelong project for you, and maybe even longer than that, to come to some great answers. And so this paper is kind of jumping into that story. There's probably been about 6 or 7 prior papers that have led up to this understanding that we'll talk about, a new way of thinking about managing vestibular schwannomas. And it's really been informed by just even in my short career, I've seen a pretty significant change in the demographical profile of patients presenting with vestibular schwannomas. It used to be that people would present with larger tumors and more symptoms and undergo treatment pretty close to the time of detection or diagnosis. And now the average person we're seeing is over 60 with pretty minor symptoms oftentimes. And so naturally the question is, do all these people need to be treated up front, or are there other ways to consider managing them? The idea of conservative management, wait and scan, there's many different names for it, observation, is not new. It was really championed by the Danish population. Ever since the 70s and 80s, they've been observing tumors. But the primary way we've always thought about managing from a conservative standpoint is once a tumor is diagnosed and it's small, you can consider watching it. But if it has any detectable growth, then that's the time to intervene. And I think the more we understand that, that's probably an early or maybe even an outdated way to think about it. And that's really the context or background for the work in what's described in this paper.
I appreciate that context. As you look back, you had mentioned that this has changed over the course of your career and that you would discover more large tumors and they would get treated. With this older group of patients, even with size increases, does size increases always correlate with new symptoms, or does the threshold just seem to vary so much that surveillance means something new now?
I think it's good to preface this by saying there's a lot of varying opinions about this particular topic. And I would say that there's very few things that are more hotly debated within neurotology and neurosurgery. And I'm just kind of presenting our perspective based on what I would consider reasonably good evidence. So when a person's first diagnosed with a vestibular schwannoma, the first thing you want to consider is the size. That's the primary determinant of what pathways they can even consider as reasonable. And a tumor that's about, it's not that you have to use a strict cut point, but generally speaking, a tumor that's about 1.5 centimeters in the angle is just starting to touch the brainstem and indent it a little bit. Anything less than that, anything confined to the internal auditory canal or just coming out of the angle about 1.5 centimeters or less, we'd call small. Those patients are really eligible, very fairly eligible for conservative management, so wait and scan, or radiosurgery or microsurgery. Once you start getting over about 1.5 centimeters in angle and probably up to 2.5 centimeters, again, people will use different cutoffs, but broadly it's a good rule of thumb, then you usually don't observe. It's already reached a size where it's starting to cause problems. And if you keep watching it and it keeps growing, you're just waiting for, worse things to happen. And so you generally recommend intervention up front for 1.5 to 2.5. And so we call those medium-sized tumors. Anything over 2.5 centimeters, it's uncommon that people would recommend radiation for those. And it's mainly managed with microsurgical resection. And those are rules of thumb. We always try to optimize our care for each individual patient based on their goals through a process of shared decision-making and informed consent. So we're talking today, this paper really is looking at the population of people with small tumors, which represents the largest group of people right now. Most people are diagnosed with tumors that are smaller in size. So the old paradigm would say you'd detect a tumor if it was small, and you'd either offer them upfront microsurgery or radiation, or you would watch the tumor. And if you watch the tumor and there was any growth, and typically our threshold for saying it's true growth rather than just test variation on MRI is about 2 millimeters. So if it grows more than 2 millimeters, then you'd say, well, you should treat it. And the old dogma was they're the youngest they'll ever be. It's the smallest it's ever going to be. And they have the least symptoms at this time. So now intervene, because otherwise you're kicking the can down the road and you're just waiting for a worse outcome when you eventually treat them. The number one predictor of outcome for any treatment for vestibular schwannoma is size. There's other things that matter, but a larger size portends a worse outcome. So naturally, shouldn't you just treat the tumor when it's smaller? But I think in that context, you also have to understand and agree that 2 millimeters of growth doesn't change your outcome. So if your tumor was 5 millimeters and it grew to 7 millimeters, there's nobody that can convince me that your outcome with surgery or radiation would be any different. And even 5 millimeters to 10 millimeters in the internal auditory canal, so very small amount of growth, 5 millimeters of growth probably has no significant bearing on your outcome. But if your tumor grew from 5 millimeters to, say, 2 centimeters, that's quite a bit of growth, and your outcome's going to change. And so clearly there's some point where your outcomes start to deteriorate more if you wait too long to watch them. And so this is the concept that we call an update to the wait and scan paradigm, and we call it threshold surveillance, meaning you're watching them until they reach a general ballpark. And then at that point, you'd say, well, this tumor has demonstrated that it's going to continue to grow. You're approaching kind of that threshold where your outcomes are likely going to start deteriorating if we wait much longer, and then intervene. So there's pretty good data that says about 1.5 centimeters in the angle, you're starting to approach that point where if you keep waiting, your outcomes probably are going to be different than if you intervene earlier.
That's great. So how has your own practice changed? Do you get a couple scans over a couple years, or is it, I guess, what is the intensity of surveillance when you think about scanning and these size parameters? If it's a small tumor, is it something where you'll tell the patient, well, we'll do it in a year, or we'll do it in 6 months, or we'll do it in 18 months? Like how, I'm sure it's not clean. I understand that, but, in maybe broad strokes, how do you operationalize this from the paper to practice?
Yeah, that's particularly for a clinical paper. You'd say, how is this impacting practice? And if it's not, then you'd say, what's the real value of the paper? I mean, it might have downstream benefits, but directly for this, I think this can change how we consider management for patients. And I think that it can improve outcomes for some of our patients. And that's the ultimate goal for all clinical research. So just generally speaking, what's the kind of recommended pathway for imaging intervals if you're embarking on an observational strategy? So the patient comes in, they're diagnosed with a 4 millimeter internal auditory canal tumor. You talk about radiosurgery, microsurgery, and observation, and they select based on their goals and what you've given them. They select to observe their tumor, meaning not intervene initially. So most people will get a repeat scan in about 6 months after the first scan. That's variable, but I'd say most people do that. And the goal of that short interval is just to detect a really fast-growing tumor, or potentially, very rarely, it's not a vestibular schwannoma and there was a misdiagnosis initially and you want to catch something that's a little bit more sinister than a histologically benign, slow-growing schwannoma. So that's that 6-month scan. And then thereafter, usually for the first 2 or 3 years following that, you'll get annual audiograms and annual MRI. And then after that, if it's demonstrated non-growth or very, very slow growth, you can keep increasing the intervals over time. So typically after 2 or 3 years, people will go to an every other year. But a couple really important points to emphasize just from a clinical standpoint is that you need to stress the importance of follow-up for the patient. I always say the only thing you can do wrong under observation is not come back at the recommended interval, meaning they leave, they hear it's a benign small tumor, and they come back in 20 years and get another scan, and all of a sudden they find a really big tumor, and we say, shoot, we could have given you a better outcome if we would have intervened a long time ago. So you missed an opportunity. So follow-up is critical. The other thing that's really important is to say that symptoms are not a barometer for tumor growth. The only way to know your tumor is growing is to get an MRI. And the reason I say that is naturally we'd all assume, and patients would assume, that if your tumor grows, your hearing will get worse because it's pushing on the cochlear nerve. And actually, there's a really poor association between the two. So you can have a tumor that's growing and your hearing remains stable. And conversely, you can have a tumor that's not growing and your hearing can actually decline. So we say you just have to get the scan. You can't use your symptoms generally as a barometer for growth. So those are just some background statements about how we think about it. But for how would we apply this idea into practice right now? The first and most important thing I want to emphasize is that we are not suggesting you should watch every single tumor for a long time until it gets to 1.5 centimeters in everybody. All this is an additional way to think about care so that you can maximally individualize treatment to meet the priorities the patient's looking for. So if a person comes in and they're 40 and they have a small tumor and really good hearing, and you've talked to everything and they have good information about all the options and they choose to have surgery, that's completely reasonable as long as they had good information to make a decision. But if they also say, look, I don't want to have surgery or radiation until I really feel like I need to, meaning it's growing and I'm starting to have symptoms. So in that patient, maybe they're a 5 millimeter tumor and they grow to a centimeter and they just get into the angle a little bit. And they say, I'm still feeling really good. My hearing's really good and I feel great. I just don't feel like I need a treatment yet. And before we would have said, you definitely do. Your tumor's growing. But really, they don't, I believe. And as long as you can get follow up and you can keep following them, if they want to follow it for a little bit of time, you can, even with a growing tumor. Just understanding that the closer you get to that approximate 1.5 threshold, that's kind of the slippery slope of increasingly worse outcome with these different treatments. Once you start approaching that, you might say, well, we've watched it, we've given it an opportunity, and it's really kind of demonstrating that it's continuing to grow. We should probably have treatment now. So your outcome will probably be about the same at that point, and they've had more of their time without a treatment, which typically, in most cases, results in better quality of life years during that interval that they didn't have treatment. Surgery rarely makes a person feel better. Radiation rarely makes a person feel better. There are exceptions, but you're giving them more time without more of their life without having those symptoms related to the treatment. And so, how do we use this? We give them all the information, and if they have a slow growing tumor, we'll keep watching it if that's what they want to do. And again, it's an additional way to conceptualize the management of this particular population of people. It's not a dogmatic thing you have to follow with everybody. It's just a new way to think about the wait and scan approach to optimize individualized care and support the best informed decision making for the patient.
Yeah, I really like that. It seems like you said, it kind of marries a patient-centered approach with some of the prior and new evidence. I suspect it resonates with patients, particularly when they're able to articulate their current quality of life, their current activity, their current function. And I was also struck by your comments about rarely does surgery or radiotherapy improve quality of life from that pre-treatment baseline. And to me, that probably sounds like a future research paper, right? That the impact on the quality or even healthcare resources or cost or impact or quality of life years, I think is the term you used.
Yep.
As you look out, like you said, this is a topic that continues to evolve in your career. What are some future directions or what's the future research looking like based on these sort of findings?
So one thing we've kind of, I think, reasonably figured out, it was a paper in 600 patients underwent a microsurgical resection. We determined kind of that tipping point of outcome being about 1.5 centimeters for surgery. The tipping point size for radiosurgery has not really been well defined. Anecdotally or intuitively, a lot of people who are involved in the radiosurgical scene would say between 2 and 3 centimeters is where your outcomes start to really deteriorate. But there hasn't been a study that looks at that tipping point very well yet. And so we're actively looking at our data to answer that question. If you watch your tumor up to a centimeter and a half, it's not like you can only have surgery. You could also have radiation or radiosurgery. So we're trying to figure out that same tipping point. And does it align with that microsurgical cut point or tipping point of 1.5? And it's not just like if you get radiation and if it's already large, your failure rate's a little bit higher, which is true. But you also get this thing called pseudoprogression. So your tumor naturally swells after even a successful radiosurgery treatment. It swells in the first 9 months to 2 or 3 years, even, and you can get some more sequela from that. But also, the thing that I always think about is the reported rates of radiosurgical failure vary by center. So radiosurgery is successful between 85 and 98% of times it's used, depending on what series you look at. So if you say your tumor control rate with radiosurgery, just kind of average that, say it's around 93% at 5 and 10 years on a Kaplan-Meier plot, that means that if it doesn't work and that's 7% or something like that, most of the time we're recommending surgery. And surgery after radiation is more difficult because it scars the arachnoid. The facial nerve is more irritable. It's been devascularized. And also the tumor's larger at that point. That's what the definition of a radiosurgical failure really is continued or sustained growth. And so in that whole question of what's the tipping point for radiosurgery, I think you have to take into consideration the risk of failure and the secondary complications that come from that secondary treatment, particularly if your control rate's about 7%. So that's what we're working on right now. It's a large data set, and it's probably going to take about another 6 months for us to get it out. But I think that piece will really help us capture this whole story a little bit more.
Yeah, well, Matt, I really appreciate your time today. I appreciate you sharing the findings of this work and its impact. I certainly learned a lot today. Any take-home points for our listener?
Just two things. The first thing was listening to the patient. We become indoctrinated in what we do, and so we only think that what we should be doing is what we've learned before, and you kind of get really narrow-minded. And a lot of times patients that have a small growing tumor, they'd feel good, and they'd say, "Well, do I need treatment?" And we'd say, "Yes, you need treatment because it's growing." And they'd say, "Well, why? Like, why do I need treatment?" And that's a great question. We'd always kind of dismiss it, but that's actually the heart of this project, is looking at their reactions to the, I'm feeling good, my tumor's small, you're saying it's benign and I'm old and I don't have a lot of symptoms. So listen to your patients. Try not to get so constrained by what you've learned. Most things we do today, we would do differently if we were taken out of the context from which we learned it and said, okay, we're going to start from scratch. We're going to redesign this. It would be very different than how most things are. Most things are the way they are now because they naturally evolved through a bunch of processes, and they almost become nonsensical sometimes when you stand back and look at what we're doing big picture. So try to pull your mind out of how you're supposed to think about it to think more creatively about things. I would say those are two things that I think are very valuable that will help improve patient care and also help us advance our field.
Well, that's great advice. I love those points, and I believe it. It's true. You can very much get caught in your own echo chamber professionally. So having those opportunities to step back and listen, I really agree with that, with the creative process and just research questions in general. Thank you for your time today. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.